Hello, my name is Metaxa, and I want to thank you for joining me in this COVID-19 session where we're going to talk about the ethical issues that have arisen and are arising during this pandemic. I've got no conflict of interest regarding this talk. So I think we've all realized that things have changed during the pandemic, and a lot of ethical questions have risen from when is it okay to restrict our movements and our freedom of movement, to who can we be told who to meet and when, use medication that have not really been trialed or checked, and if there's a vaccine, would the vaccination be compulsory? And if there's a vaccine, who gets vaccinated first? Us, the healthcare providers, the vulnerable groups, the children. There's a lot around the ethics of the ethics of research in a pandemic. So how to conduct robust and effective research, and how to actually publish your results. But I'm not going to talk about any of this. I am going to focus on the very difficult decisions that we have asked, and hopefully not, but will be asked to make during a pandemic, around who gets to come into intensive care and about limitations of life-sustaining treatment for patients that are already in intensive care. And I think you will agree with me when I say that the last few decades, it has all been about the autonomy of the patient, respecting their wishes, them making their wishes known to us. Our focus as clinicians have been on the patient, and our decision-making have been around the best interest of that individual patient. Long gone are the days where the paternalistic doctor would make decisions about a patient without involving them or their family. The families are now involved throughout. And much has been talked about autonomy, but very little about justice and about resource allocation, about the finite of resources. This has been a topic that hasn't really been discussed in the last few decades or years. But of course, this has changed during a pandemic, and the focus seems to have shifted from the individual autonomy to a more relational autonomy, where we remembered again, it has been highlighted again, that the patient is part of a society, is part of a group, and now our decisions probably need to move from the individual best interest to a more population-wide societal best interest, a more utilitarian approach where all of a sudden what matters is to save the most lives. And in this frame, then we start talking about rationing, and we start talking about triage. So the first question that we need to answer when we're asked to answer is who gets admitted to this last ICU bed, who gets this last ventilator, and then what springs from that is we're asked, or will be asked maybe, to answer questions about who do we care for first, who do we give our last treatment to first, and how can we judge who is more likely to benefit from a treatment? And this, of course, is called triage. And if you think that this is the first time we're asked to triage our patients, you only need to think about a very busy day in your ICU where you have 1 or 2 maximum sick patients, and how all your thinking goes to these patients and what happens to the rest of them. So yes, we have been triaging all along in our career, but maybe more subtly, we're now asked to triage during a pandemic quite bluntly about who lives or dies if they stay out of intensive care. And when are we allowed, when should we start making these life and death decisions? And this is a very, very nice, very recent paper from a consensus, from an expert consensus group, who basically looked at and talked about rationing depending on capacity. And you can see here that when we are in, let's say, moderate demand, when we have moderate demand on resources, then we can ask and do moderate measures. So for example, canceled routine surgery, for example. When the surge and the demands increase, then we start when we start adapting and creating more measures. So for example, expanding our ICUs to other areas like recovery, or using anesthetic machines and ventilators as ICU ventilators. But look what happens when we reach major surge, or basically a crisis surge, is when we are more than 200% in our capacity. And then, and only then, we start triaging and start reallocating our ventilators, let's say, from one patient to another. So two things here to notice in these consensus statements: that we only start triaging when we have reached crisis, and we don't preemptively do that just because we think we won't be able to care for all the patients that are coming. The second thing is, this triage is not something that you or I individually will do. So it's not something that you will do when you go to a shift and you decide, oh, I'm just going to start triaging patients now. And it's not even something that the hospital will do in isolation. It is something that will come more centrally. It's a regional allocation of resources. So someone more centrally needs to decide that we are now entering triage and rationing. Another thing that I would like you to notice is that I can only assume that this percentage is here. When we talk about capacity, we're talking about ventilators and beds. But I hope you agree with me that ICU is more than the beds and more than the ventilators, and other things can run out in times of a surge, like, for example, staff. And a question that should be answered is, what exactly is the right, for example, ratio between an ICU nurse and a patient during a pandemic? What is the moral ratio, for example? Is it 1:1? Is it 1:3? Or is it 1:6? And when exactly are we entering this crisis, this major surge? So we've decided now that it's not going to happen until we reach maximal and exceed maximal capacity. But how is it going to happen? And this is a very, very nice paper from a Canadian group that was published before the COVID pandemic. And it did talk about the allocation of ventilators if indeed there is an influenza pandemic. And the good thing about ethics is that there is hardly ever a right, an absolute right or wrong. So everything is up to discussion within our society, or each one's society, to decide which ethical principles they want to abide to. And they've discussed about these ethical principles, and I'm just going to focus only on a few of them. So this is the life cycle principle, where you allocate priority to those who have less opportunity to live their lives. So I think this is a way to talk about age without really talking about age. Another principle you can abide to, or you can apply, is the first come, first served. And I don't know if that makes you feel all of a sudden very comfortable. And if it does, it's because what we do, right? We go to work, and whoever comes through our doors, we treat them. And it does give you a sense of fairness. And that is, though, until you start thinking that maybe whoever comes first is someone that lives close to the hospital, or has the money to take a cab to come to the hospital, or actually trusts us in the hospital to come to us. And then it becomes, that principle becomes also quite ethically complicated. A random selection, I think, it's a lovely example of a principle that is very, very equal, but maybe sometimes not very fair. And I think we can all agree that when we talk about prioritizing people according to their social or moral worth, then we might run into trouble, because we have to agree on some characteristics that us actually deem worthy, and this is going to be probably problematic. So that's fair and square, but what happens in practice then? And I think throughout all the literature that has been published the last couple of decades, there is an agreement that, pandemic or not, now COVID or not, COVID or non-COVID patients should be treated equitably according to the same criteria. And this is a very recent publication. It's a synopsis of professional bodies and the guidance they have issued around this area. And this focuses only on European bodies. And you can see that there is agreement in that around the bodies that basically says all patients, COVID or non-COVID, should be treated equitably. But very interestingly, there is some disagreement. So for example, not all societies agree who and how actually we are going to decide who to prioritize. There are some that will focus on, for example, short-term survival, where are others that will focus, like the UK's one, only on frailty and will also focus on comorbidities and longer-term survival. But even more importantly, not many guidelines, apart from the Italian ones, actually talk about age, blatantly age. People talk about the rest of the guidance do make a point in saying that age and age alone should not be taken into account, and it's not a good criterion for triaging. So to make it even more specific, this is from Ontario, and it has also been endorsed and adopted by the New York State, where this is a proposed pandemic triage protocol. It has 3 steps, as you can see. First of all, you need to assess and see whether the patient meets the inclusion criteria, so basically whether they need to be in intensive care or not. And then they need to see whether they have exclusion criteria or not. And we're going to talk about the exclusion criteria in the next slide. Then some points are attributed to the patient. According to the points, you get color-coded, and then we decide whether you get into ICU or not. And these are the exclusion criteria. And take a minute and see, we're talking about severe comorbidities, whether you have a recurrent or a witness cardiac arrest, whether you have a metastatic malignancy with poor prognosis, burns, or end-stage organ failure. And I don't know, maybe you look at these criteria and you say, you know, it's fair enough, these are very sick patients. But I would urge you to ask yourself this. Remember that we are talking about patients that this way they're going to be completely excluded. So for example, someone without COVID that comes with urosepsis and needs some vasopressors will be not admitted into ITU. This is what happened in the UK, and you see that in the UK everything is very focused on frailty, and these guidelines have been revisited because there was a massive public backlash when frailty was not clarified, that it cannot really be applied in stable long-term disabilities. Very quickly about when do we stop. So we stop again by applying SOFA criteria and reassessing in 2 and 5 days. And if the patient is not getting any better, again, this is from the Ontario and the New York guidance, then we stop. What we need to be very clear on here is that we're talking about a SOFA score that hasn't been validated for individual patients. And this editorial speaks very clearly. What we need to make sure is that we need to be very clear with the families of these patients that we don't stop because of futility, but we stop because someone else needs the ventilator. And my last slides will be on how we need to continue to earn and keep this public trust, because nothing can be done in a pandemic without it. And this is how the public has reacted to some of the things that happened during the pandemic. And you can see the outcry about the frailty score. You can see the shock when people found not resuscitation forms when they didn't look at them, from Italy, from New York, all around. So it's very important that we keep when we make guidance, we make sure that they are inclusive, that they are transparent, that they are reasonable, and someone in the end is held accountable for them. And this is endorsed by the WHO. I'll close here. Thank you very much.